Video as a Service, or VaaS, was originally developed as a turnkey telemedicine service to aid in the treatment and diagnosis of stroke. It has since evolved into a subscription-based service providing a low cost of entry. The VaaS cloud service is built on Polycom infrastructure, is standards-based and therefore endpoint agnostic.
We've got a secure network link between the patient's home and the hospital site, so we know that information's secure and data secure. The connectivity is very good and it's limitless with regards to what we're trying to achieve here.
Fundamental to the VaaS service is the proactive monitoring and management of the core infrastructure. In support of that, there's a 24/7 help desk that the clinician or nurse operative can make use of.
We decided to implement VaaS, Video as a Service, so we could deliver the quality to anywhere we wanted at any time. The initial project we installed on Video as a Service was telestroke. This is in response to a Department of Health initiative. Now, across the region, there's something like 500 patients been treated. There's been hundreds of lives saved, and in monetary terms, that's about £6.5 million a year saving. The other major project was renal home dialysis. The key points for us were the quality of the video, so the technician or the consultant could speak to the patient, but also the importance of real-time telemetry from the home into the hospital. And that ensures the quality of the service being given to the patient. The patient feedback is that they are really, really pleased by the service in the home and actually wouldn't want it done any other way. Imerja actually hosts Video as a Service. They're the supplier that will go into the homes or into the hospitals and actually install the equipment and ensure that it's technically working and to the standard that the end user requires, which is really important, particularly for a patient in a home, but also when you're delivering complex MDTs.
Using the Video as a Service, working in partnership with Imerja, has been a definite benefit for us with regards to the support and the infrastructure that's immediately here for us. Having Imerja in the background while we're using the Video as a Service is very reassuring to us.
We chose Imerja for the technical support and expertise, and we chose Polycom for its video clarity because the video needed to be the same as assessing the patient face to face.
They've proved to be of major benefit for every service we've put in for the quality of video that we're receiving across the network. We now want to roll this more into primary care type scenarios where we can run virtual clinics from GPs in Lancashire or South Cumbria. The subscription-based service that we've created enables patients to be wherever they want to be.
Lancashire Teaching Hospitals provides a regional service for all dialysis patients. We cover the whole of Lancashire and South Cumbria, and we go all the way up to Barry-in-Furness, which is about 100 miles from here. Having the facility to put the Polycom equipment in a patient's home in a lot of these rural locations, it allows a patient to stay where they are. It enables them a lot more control over their dialysis and the times that they use the system, whilst also having the ability to speak to a nurse or another healthcare professional at the end of the video screen.
Normally patients who dialyse in the hospital will come into the hospital 3 times a week, and the treatment usually lasts about 4 hours. And with that you've got to put onto the factor of journey time into the hospital.
Instead of the patient spending a lot more time in the hospital setting, they can go home earlier with the ability for the nurse to see the patient in the home setting and advise them. The nurse can zoom in out of the room and to the parameters on the machine or to the patient's arm whilst listening to what the patient's got to say.
The first 3 months is probably the most likely time that the patients would have difficulties. With a video call we can resolve the problem and avoid patient admissions back into the training unit. So it's very high definition, so we can actually see every aspect of the dialysis treatment as if you were in the room with them.
It's empowered patients. It's allowed them the freedom to sort of stay at home and dialyse at home. John Slater is about 40 miles away from Preston, and he's been able to go home earlier with dialysis.
Dialysis patients, their memory isn't very good, and obviously getting on dialysis machines, there's a lot to remember. So if he needs anybody, he's got somebody there within a second who can just click the button and he's straight through to a nurse who can coach him through any issue. The benefits for us are that he's home all the time, so that means he's much calmer.
And I like to be independent, and this gives me the independence that I like. I'm not stuck to 9 till 5. I can do it in the evening, or I can do it in the morning, do it at the weekends. It gives you the freedom, but it is better for me to have the home care here. It's like being in the room with them.
A couple of years ago, I had a challenge in that we have patients in nursing homes who require swallowing assessments, and there are not enough therapists to see those patients. I thought that perhaps we could use technology to assess those patients.
We use tele-swallowing as part of the normal service delivery for patients in the community with dysphagia. Those people have swallowing problems at all levels, one of which is called pharyngeal dysphagia, and that can be life-threatening.
We've worked in collaboration with our colleagues in the nursing homes to be able to access those patients more rapidly and try to help them before they deteriorate too far and have to be brought into hospital.
The patient has much speedier access to speech therapy interventions. I can do a full assessment and make the recommendations there and then.
We could see the patients very clearly, and we could zoom into the mouth and to the oral cavity, which were vital for our assessment. It increased speech and language therapy capacity, it increased their productivity.
By doing the assessment with technology, we've actually reduced our assessment time to 30 minutes. We've outsourced the preparation, and what we do now as speech and language therapists is that we focus on our core skills. We can then deflect that time dispensing more intensive therapy for people on the stroke unit. So the tele-swallowing trial has been successful. Not only does this project deliver a modern approach to swallowing assessment, it also can deliver potentially huge cost efficiencies. Polycom helps us to defy distance between our patients and the therapy services.
This is a multi-specialty tertiary children's hospital. We look after 270,000 children in outpatient attendances every year. They may be here for literally a 10-minute outpatient appointment, having travelled for 6 hours. Video allows us to extend our reach to be able to deliver that tertiary specialised care near the patient's home rather than having to travel long distances. It becomes ingrained within their everyday clinical practice. One of the most important aspects of the technology is actually the ability to share content, desktop content. We will also be able to share imaging, and I'll be able to walk through the images with both the paediatrician and families. The essential benefit of video telemedicine is improving access to specialist knowledge, which is very constrained. Often the paediatrician, they will request advice, not just from us in paediatric neurology, but also colleagues in other specialties. Sometimes the condition does need to be treated earlier to improve outcomes, and often the children and families may wait for weeks or months. A child who's admitted with optic neuritis, this is a condition which causes sudden visual loss, is not seen very often in paediatrics. We were able to successfully treat her without having to bring her here. Telemedicine has allowed us to improve the speed at which a valid assessment of the child can be performed and improve the outcome.
My name's Elaine Day, and I'm Service Improvement and Development Manager for the Cardiac and Stroke Networks in Lancashire and Cumbria. And I've had the pleasure of working on this telestroke project over the last couple of years. Our area is Cumbria and Lancashire, and it has a population of 2.2 million. We have approximately 4,000 to 4,500 strokes a year, and out of that, 10% of those patients would be eligible for stroke thrombolysis. Stroke thrombolysis is the drug of treatment for patients who've had a blood clot, not a blood hemorrhage type stroke. It needs to begin within 4.5 hours of onset, and within that 4.5 hours they have to reach hospital, they have to have an assessment, they have to have a CT scan, and then thrombolysis given if it's appropriate.
Because of the geography in Cumbria and Lancashire, we have a big rural population, and because of the travel times involved, the only way that we could provide a meaningful, equitable 24-hour service across our geography was to look at either a local provision or a telestroke solution.
And we thought that we would quite like to go with the multi-sense Polycom kit.
I think the main advantage of using the Polycom cart is that we've really enhanced the quality of stroke care for the patients in the Cumbria and Lancashire network. I will dial into the remote telecart, and that's simply by the press of a button on my PC at home. I can then video conference and have picture within picture. I can then see the patient at the far end and the staff at the far end. I can remotely control the distant camera so that I can pan and zoom to very high quality, so that I can even zoom in and see the state of or the size of people's pupils. And then I can do a neurological assessment of the patient and then make a diagnosis and a judgment about whether they should be treated or not.
It's because it's so essential that once the consultant on the shift here goes home, obviously then they're in the hands of the telecart, if you like. It's absolutely an amazing piece of equipment in the fact that it does, they can determine the diagnosis from that picture, from whatever distance that might be within the northwest of the area.
For a really quite small financial outlay, they've got a 24-hour consultant-led service for their stroke patients.
It's an absolutely fantastic piece of equipment.